Good morning, everyone. And it's a pleasure, and I feel humbled and privileged to be here today to offer a small token of contribution in this memorial to Dr. Gillies, someone who I consider a giant in the field. And I sort of grew up scientifically reading his papers. So a lot of the work that I'm going to show you what we're doing at the University of Pennsylvania is very much inspired by his vision and the work in the field. Oops. Okay. Great. So a lot of the work that also Dr. Gillies sort of envisioned is sitting in the interface between data science, translational work, radiology, multi-omic integration, and what has come now to be coined as also integrated diagnostics. So a lot of this work sort of served as a translational catalyst between computational imaging science and clinical sort of cancer research. I'm going to give paradigms here for some of the work we've done in breast cancer, which is the majority of the work we've done so far, although the paradigm can easily be expanded to other sort of solid tumors. And I'll talk a little bit about our ability to characterize heterogeneity, which builds also to what we just heard in the two previous talks. So a lot of this work is really built on developing and integrating image analysis work, pattern recognition, machine learning and data mining approaches coming from more traditional computer science, computer vision fields, but bringing them together on clinically relevant applications in cancer research. And particularly where our interest has laid in the past several years is to investigate the role of imaging as a prognostic and predictive biomarker for personalized clinical decisions in precision cancer care. And the way I see this is kind of splitting the continuum of cancer care in three main themes: screening and prevention, prognosis, and treatment. So in breast cancer in particular, we've worked across all kinds of different modalities, digital mammography, breast tomosynthesis, MRI, ultrasound, PET, and looking at multimodality imaging biomarkers. I'm myself a computer scientist, so I started by looking at these images kind of agnostically, and then I sort of learned my lessons that I should never look at these images kind of agnostically. And that's a lot of lessons learned. So a lot of our work has focused on characterizing heterogeneity, not necessarily of tumors, but of the normal tissue. And especially when it comes to breast cancer, there's been a lot of work highlighting the importance of breast density as a risk factor of developing breast cancer, and statistical modeling approaches and incorporating breast density measurements into risk prediction models so we can identify women that may be at high risk and need more intensive screening or supplemental screening versus the women that are low risk and maybe could be spared some of the side effects of screening with not as intense screening approaches. And so as Dr. Gillies said, images are data. So we started thinking about how can we move beyond the conventional measurements of breast density, which is just a binary measurement in a simple way, the bright stuff in a mammogram versus the dark stuff in a mammogram, and think of a mammogram and the parenchymal pattern as a more sort of complex data set and looking at characterizing the complexity of the breast parenchymal tissue. The idea about the complexity started sort of that the complexity maybe can hide tumors, contribute to masking, but also that not all dense tissue is the same. And there may be something in the pattern of the breast tissue that may be contributing to the risk of developing breast cancer. So going from the original digital image to the pattern image, we saw a lot also in Dr. Gillies' group about features such as entropy. By taking that from a tumor, let's say, and expanding it to the entire breast area and deriving this sort of feature maps that they then use machine learning and data science approaches to parameterize and incorporate into risk modeling approaches. And here's a heat map that we've also seen a lot in Dr. Gillies' work, some of the pioneering work looking at how we can take radiomics and treat them in a similar way as we would use other omics data, gene expression data, and so forth, and apply similar bioinformatics techniques to try to unveil radiomic phenotypes. Here, instead of looking at the phenotype of the tumor, we're looking at the phenotype of the entire breast tissue and trying to uncover patterns that may be related to the risk of developing breast cancer. And what we saw here in a paper published in Radiology in 2019, that using similar approaches, we were able to identify statistically significant phenotypes of the normal breast parenchymal pattern in women that were not necessarily linearly associated with breast density, conveyed somehow different information, and they were also able to add to the discriminatory ability of a regression classifier in looking between women who develop breast cancer versus women who not, even when we account for breast density. And I will say that personally, I was also very inspired from this work from some of the early papers from Dr. Gillis's group. We saw that paper with Hugo Ertz as the first author, and also Dr. Geiger's group at the University of Chicago, and sort of coming up with some of these approaches and putting them together and trying to characterize the phenotype of the parenchymal pattern. Evolving onto this work, of course, deep learning and artificial intelligence is coming into the field. And I see this as a way, you know, a lot of the times we talk about, radiomics versus neural networks. And however, I don't think that they have to be sort of once against the other. I think we can use sort of neural networks and artificial intelligence to help us make more sense of the feature maps that we're extracting, especially in these applications when we're talking about hundreds or thousands of feature maps from the entire breast area. So there's rich data, and thinking about how we can take these models to leverage the information from radiomics and combine them to generate predictions of outcomes. And this is some work we're starting to do, and we hope it's going to be a promising field trying to combine both of these approaches, but also use artificial intelligence as a way to further explain the patterns that we look at the breast. So get back to some of the biological hypotheses, look at what are the networks are identifying in the images that may be contributing to the risk of breast cancer, and then start thinking about the biology that may be underlying these patterns. Are we finding areas that are consistently at the same, at different parts of the breast? And what does that mean with the underlying, let's say, anatomy of the breast or the hormonal processes in the breast? And how can we use artificial intelligence, not just as a black box that can help us improve the prediction, but also take us back to the hypothesis generation area and try to think about what are the biological processes that contribute to risk, and maybe if there are any ways that we can intervene on those biological processes and maybe reduce risk as well. And then going from the characterizing the breast parenchyma of the normal tissue, thinking again about the tumor phenotyping, similar approaches here in the breast as a lot of the work that done Dr. Gillis's group, and a lot of that has been inspired by the work in Dr. Gillis's group. And so looking here at developing pipelines to automatically identify the lesions in the breast, extract features. Here I'm showing an example of a breast dynamic contrast enhanced MRI scan, where we have the ability to also extract some functional descriptors of how the contrast is taken up by the tumor, and then looking about how we correlate these features with some of the conventional histopathology characteristics, as well as some of the emerging molecular profiling assays. But more importantly, I think, is how we put those things together to try to predict outcome and find complementary strengths in the information that imaging is providing versus molecular assays versus histopathology, and putting all the pieces of the puzzle together. And we heard a lot about, in the two previous talks, about heterogeneity. And we're getting really good now with the field of radiomics and AI in characterizing heterogeneity radiographically and with imaging data for tumors. So we can see, for example, this image, and we can say, oh, this area represents an area that's distinct from this area, the blue areas versus, and so forth. I really like the term habitat imaging very much. And I was really excited when that term was originally coined by Dr. Gillis's group. But we're not really good at, and I think this is something that we need to come together as a field, is to understand what these areas are all about. So we can tell that, oh, maybe this tumor has 3 clusters, 3 different habitats or whatever, but we really don't know what's going on and what makes them different. Usually the information that we have when we do these correlative studies comes from a biopsy that can be from any part of the tumor. And there's a lot of work on ours included and others. And we're trying to correlate the imaging phenotypes with, let's say, Oncotype DX score, Mama Print score, or whatever, histopathology. But really, we're not comparing apples to apples. We're comparing apple to a bite. That's the biopsy, right? And we're really not seeing the full picture. So to do the studies that will take us from a spatial and temporal matching of the heterogeneity that we see from imaging to a spatial and temporal matching of the true biological heterogeneity that we see in histopathology, I think is a very difficult task, and it requires multiple disciplines to come together to be able to establish that, going from, high dimensional imaging all the way, maybe even to single cell analysis. And I think that's something that we need to be thinking as a field and coming together to try to decode. From spatial tumor heterogeneity, imaging with high dimensional data, such as molecular imaging or high dimensional breast MRI imaging data, can also allow us the ability to perform computational analysis in the temporal dimension. And here, for example, we've done some work looking in the temporal dimension of FDG PET and high dimensional sort of dynamic acquisition. And again, using statistic and machine learnings, trying to get down to that concept of habitat imaging, identify different parts of the tumors that may have similar functional characteristics, and then extracting information from these areas that we can use to try to supplement conventional histopathologic and prognostic markers. And some of our works and others as well in the field is starting to consistently show that these measurements don't just correlate with surrogate prognostic markers, such as, Oncotype DX score, mamma print histopathology, and so forth, but can have value in predicting outcomes even when we account for some of those conventional prognostic markers. Here, we're looking again at radiomic phenotypes of primary invasive breast cancer patients across sort of all the different sort of receptor types, and looking at what happens when we build Cox regression models in which we also account for conventional histopathology and prognostic markers. We still see that the radiomic phenotype has independent value in predicting actual recurrence outcomes. And these are difficult studies to conduct, especially in breast cancer, because to really have a good sense of recurrence outcomes, you have to follow the patient for up to 10 years at this point. By that point, the imaging modality you were using at baseline probably is a little bit outdated. And so it feels like you're kind of chasing your tail. But the idea is here that, if you can see a signal with imaging that may be outdated by the time you have all the outcomes, or maybe not the state of the art, and you can still see a signal in terms of the independent prognostic value, one can only assume that if you had even better image quality, you may even able to get even better signal to predict recurrence. And we can see in some of our studies that these measurements tend to correlate also with what would you expect to be prognostic indicators, such as differentiation of the tumor and so forth. And ultimately, when we're looking at predictive markers, looking at response in the course of therapy, we can leverage methods such as registration to not only look at that heterogeneity at baseline, but also look at how that heterogeneity changes over time, and if we have development of de novo resistance. And these are some markers that may be very interesting, especially when we're looking to identify responders or non-responders early in the course of therapy, as we saw in the previous talk about immunotherapy as well. And here, for example, in the context of the I-SPY1 trial, we saw that when we layer on tumor heterogeneity metrics in the conventional functional tumor volume measurement, we can further separate women who were predicted to do worse based just on functional tumor volume into two sort of curves, one that sort of ends up grouping with the women that tend to have better outlook, and that may be a strategy to reduce to de-escalate some of the therapy, especially chemotherapy for some of these women. And so by that, I'd like to reiterate what is very largely Dr. Gillis's vision on integrated precision diagnostics, where the field of machine learning and data science and imaging science needs to come together, and not looking at imaging in isolation anymore, but looking at imaging integrating with electronic medical health record data, conventional pathology, emerging molecular profiling assays, digital pathology, and so forth, into multi-parametric models, personalizing screening, prognosis, and treatment of cancer. And of course, this is a very highly multidisciplinary work. We work very closely with collaborators from Penn and outside of Penn, different disciplines. And I would like to acknowledge everybody who's contributed to this work. But most importantly, I want to acknowledge today Dr. Gillis for his vision. He was a good friend of Penn. He would come and give talk to us at a computational biomedical Center for Image Computing and Analytics. Most recently, he was there visiting right before COVID, and giving us a talk. But I have to say that the first time I met Dr. Gillis in person was probably 10 years before that, or even a little more. He came to give a talk at Penn, and I was very, very early junior faculty, and I was in awe of the giant of radiomics coming to give a talk at Penn. And Dr. Gillis was so kind, so generous. The way he talked to our group, which was very small at the point, and to me as a junior faculty, truly inspired me to kind of have a role model, and also find the strength to build a group from ground up and move on in the field. So I owe him a lot in that sense. So thank you.